Okay, let's unpack this. Ethylene glycol. Most of us probably just know it as antifreeze, right? That's stuff in the garage.
Necessary, but definitely toxic.
But what happens if someone actually ingests it? It kicks off this time-critical chain reaction in the body. It's quite phased the way the toxicity develops.
It absolutely is. And our source material for this deep dive is a detailed clinical review on ethylene glycol toxicity, really current medical literature.
Yeah, okay.
And our mission today really is to synthesize why this stuff is so dangerous. It's not the ethylene glycol itself initially, but what your own liver turns it into. That's the crucial part.
And the setup for this is just insidious, it's colorless, odorless, but it has this one characteristic that's, well, frankly, dangerous. It tastes sweet.
That sweetness is a huge factor, especially in accidental ingestions. You know, while most cases we see reported in the U.S. are unfortunately intentional adults over 20, sometimes suicide attempts, or even trying to get intoxicated without alcohol, we absolutely cannot ignore the accidental poisonings.
That data point you mentioned from the sources is pretty sobering.
It really is. Think about 2016 data from U.S. poison control centers. Thousands of ethylene glycol cases reported, sure, mostly adults, but 686 of those cases, kids under 12.
Wow. Just because it tastes sweet.
That's the big draw. You've got this sweet-tasting liquid, often stored improperly, maybe in a garage where a child might find it. The danger is immediate.
And it doesn't take much, does it? We're talking serious toxicity here.
Shockingly little. The potential lethal dose is estimated around 1 to 2 milliliters per kilogram of body weight. That's for a concentrated, 95% solution.
Our small child, that's a tiny sip. A disastrously small amount.
Exactly. A minuscule, potentially lethal sip.
So swallowing it is the main route. Getting it on your skin, the source says, isn't a major pathway for toxicity. Minimal absorption there.
Correct. Ingestion is the overwhelming concern.
Okay, so the risk profile is grim, especially for kids, because of that taste. But let's get into the chemistry. Because that sweet sip is just step one. This is where it gets really interesting. How does the body actually turn a sweet liquid into a deadly poison?
Right. So the ethylene glycol molecule itself, the parent compound, e.g. we call it, it is osmotically active. It can make you feel a bit inebriated, kind of like regular alcohol.
Okay.
But on its own, it's generally considered non-toxic, or at least much less toxic. The real damage comes from its metabolites, what your body breaks it down into.
And that breakdown happens mainly in the liver, yeah.
Primarily in the liver, yes.
Yeah.
And there's one key enzyme that starts the whole dangerous cascade. Alcohol dehydrogenase. Think of it like the ignition switch for this toxic process.
The same enzyme that processes drinking alcohol.
The very same. It's designed to oxidize alcohols, but when it gets hold of ethylene glycol, it starts this serial oxidation process, creating progressively more dangerous byproducts. It's like a ticking clock.
So walk us through that clock. What are the steps?
Okay, step one. Alcohol dehydrogenase oxidizes ethylene glycol into glycolaldehyde.
Okay.
That's quickly oxidized further by another enzyme into glycolic acid. Now, this is the main villain for a while. Glycolic acid hangs around, it accumulates.
And that's what causes the acidosis.
Precisely. It's the primary driver of the severe anion gap metabolic acidosis we see. The buildup of this acid seriously destabilizes the body's pH balance. This is when the patient really starts to become critically ill.
A major internal pH crisis caused by this one metabolite. Okay, what's the next step after glycolic acid?
The glycolic acid is then oxidized into the final major toxic metabolite, oxalic acid. And this one is particularly nasty for the kidneys.
Nephrotoxic, right? Kidney destroying.
Exactly. Oxalic acid does two terrible things. First, it has a really high affinity for calcium. It just grabs calcium ions right out of the bloodstream.
Leading to low calcium levels.
Yes, hypocalcemia, which is dangerous in itself. Low calcium can cause muscle spasms, tetany, seizures, even dangerous heart rhythm problems like QT prolongation on an ECG.
So a systemic electrical problem on top of the acidosis.
Correct. But the second hit from oxalic acid is maybe even more insidious. When it binds with that calcium, it forms these tiny insoluble crystals. Calcium oxalate monohydrate crystals.
Crystals, like kidney stones.
Sort of, but these deposit directly within the renal tubules, the kidney's filtering tubes. They physically obstruct and damage the tubules, leading to acute kidney injury. It's like microscopic shards of glass clogging up the works.
Wow. Okay, that progression, e.g. to glycolaldehyde to glycolic acid causing acidosis, then oxalic acid causing hypocalcemia and kidney crystals, that's the core toxic pathway.
That's the sequence. And understanding that sequence is critical because the patient's symptoms and lab results change dramatically as they move through these stages over hours.
And the timing depends heavily on how much they ingested, how long ago, and crucially whether they also drank any regular alcohol, ethanol, at the same time.
Yes, ethanol co-ingestion is a key variable. Because alcohol dehydrogenase prefers ethanol, drinking regular alcohol can actually slow down the metabolism of ethylene glycol, delaying the toxicity. But it complicates the picture.
Which leads us straight into the diagnostic challenge, right?
Yeah.
Clinicians are facing this evolving picture, trying to figure out what's happening based on these shifting chemical markers. You mentioned GAPs earlier.
Yes, the famous GAPs. This is often the crux of early diagnosis when you're waiting for specific lab tests. We look at the osmolar gap and the anion gap.
Can you break those down for us? What do they actually tell the clinician?
Think of them as indirect clues. The osmolar gap is elevated early on when there's still a lot of the original ethylene glycol, the parent compound, floating around in the blood. It adds extra osmolase particles to the serum that aren't normally accounted for.
So high osmolar gap means the poison is present, but maybe hasn't been fully metabolized yet?
Generally, yes. In phase 1, the early phase, maybe 0 to 4 hours post-ingestion, the patient might just seem intoxicated, maybe some CNS depression. The labs will show that elevated osmolar gap, but often the anion gap is still normal. The acidosis hasn't kicked in yet.
Okay. And the anion gap?
The anion gap measures unmeasured anions, negatively charged ions in the blood. As the ethylene glycol gets metabolized into glycolic acid and other acidic byproducts, these accumulate. They represent those unmeasured anions. So a rising anion gap indicates the acidosis is developing.
Got it. So as the liver does its work.
Right. We move into phase 2, the mid-phase, maybe 4 to 12 hours. The ethylene glycol is being used up, so the osmolar gap starts to close. It goes back towards normal.
Because the parent compound is disappearing.
Exactly. But now, the glycolic acid is building up rapidly, so the anion gap widens, often dramatically. The patient starts feeling much sicker, maybe hyperventilating as their body tries desperately to blow off CO2 to compensate for the metabolic acidosis. This is the real danger zone.
And if treatment doesn't happen or is delayed past this point?
Then you hit phase 3, the late phase, 12 hours or more. Now you see the consequences. Evidence of kidney damage, rising creatinine levels, maybe decreased urine output, the acidosis is severe, systemic illness, the calcium oxalate crystals are doing their damage.
This must be incredibly stressful for the clinicians because the definitive test, the one that measures the actual ethylene glycol concentration using gas chromatography,
Yeah.
that takes time, right?
Hours, sometimes even days, depending on the lab. You simply cannot wait for that confirmation if the clinical picture suggests ethylene glycol poisoning, especially if the anion gap is climbing.
So you're relying heavily on the patient's story, if you can get one, their clinical state, and interpreting these shifting gaps in real time.
Absolutely. And here's a critical point from the sources. You cannot rule out ethylene glycol poisoning just because the osmolar gap is normal, especially if the patient is already acidotic.
Why is that?
Because if they're already acidotic, it likely means they're further along, maybe in phase 2 or 3. The original ethylene glycol might have already been metabolized away, closing the osmolar gap. But the toxic acids are now present, causing the high anion gap. The absence of an early sign doesn't mean the danger isn't present later.
That makes sense. A tricky diagnostic path. What about asymptomatic patients who come in early?
If someone comes in soon after a suspected ingestion, seems perfectly fine, and their initial labs, including acid-base status, are normal, the standard approach is often a period of observation, usually around 12 hours.
Watching for those gaps to change.
Exactly. Monitoring closely to see if metabolic acidosis develops. But there's a caveat. This observation period is only reliable once you've confirmed their blood ethanol level is undetectable. You need to make sure regular alcohol isn't masking the onset of e.g. toxicity.
Okay, so diagnosis hinges on timing and interpreting these evolving labs. What about treatment? The goal must be to stop that first enzyme, alcohol dehydrogenase, right? Stop it from making the toxins.
That's the core strategy. We need an antidote that blocks or inhibits alcohol dehydrogenase.
And what are the options?
The primary treatments are fompizole or ethanol.
Fompizole.
Yes, brand name Antisol. This is really the preferred antidote now. It's a potent inhibitor of alcohol dehydrogenase. It's relatively easy to dose, doesn't cause intoxication itself, which is a huge plus, and it's very safe with few significant side effects.
Sounds ideal. What's the catch?
The catch is cost. Fombisol is quite expensive.
Ah. And the other option is ethanol, regular drinking alcohol. That sounds counterintuitive, treating alcohol poisoning with alcohol.
It does sound odd, but it works on the principle of competitive inhibition. Alcohol dehydrogenase actually has a much higher affinity, like a stronger attraction for ethanol than it does for ethylene glycol.
So you flood the system with ethanol.
And the enzyme gets busy metabolizing the ethanol, effectively ignoring the ethylene glycol. It buys time and stops the production of those toxic metabolites, glycolic and oxalic acid.
So you end up with a very intoxicated patient who needs close monitoring.
Exactly. Ethanol is much cheaper as a drug, but managing it is complex. You have to maintain a specific target blood ethanol concentration, usually between 80 to 120 milli-GDL. This requires frequent lab checks, careful IV infusion adjustments, and because the patient becomes significantly intoxicated, they almost always need ICU-level monitoring.
So the overall hospital cost might end up being higher with ethanol, even if the drug itself is cheaper.
That's often the case, yeah. The increased monitoring and ICU stay add up. Fombisol is generally preferred if available due to its ease of use and safety profile.
When do clinicians pull the trigger on starting treatment? Especially the EG level isn't back yet.
The guidelines are pretty clear. Treatment should definitely start if the measured ethylene glycol concentration is greater than, say, 20 to 25 milli-GDL.
Okay.
But realistically, you often don't have that number quickly. So you treat based on strong clinical suspicion plus evidence of significant metabolic acidosis, for example, if the serum bicarbonate level drops below about 15 millimol. Or if there's already evidence of kidney injury starting, like rising creatinine, you don't wait.
Makes sense. What about dialysis? Getting the poison out directly?
Hemodialysis is definitely an option. Ethylene glycol itself and its toxic metabolites, like glycolic acid, are readily dialyzable. They can be effectively filtered out of the blood.
But is it always needed?
Not necessarily. If fombisol is started early, before severe acidosis or kidney damage sets in, dialysis is often not required. The antidote prevents further toxin production, and the body can usually clear what's already there, albeit slowly.
So dialysis is reserved for more severe cases?
Yes. It's strongly considered or even required if the patient presents with established renal failure, very severe metabolic acidosis that isn't correcting, or significant electrolyte problems like the hypocalcemia we talked about.
Are there any other treatments mentioned? I think the source touched on some vitamins.
Ah, yes. There's a theoretical benefit to giving cofactors like thiamine, vitamin B1, and pyridoxine, vitamin B6, and maybe magnesium. The idea is that these might help shunt the metabolism of glycolic acid down less harmful pathways, potentially generating less of the toxic oxalic acid.
Theoretical, but maybe helpful.
It's often done, low risk, potential benefit, especially in severe cases alongside the primary antidotes and supportive care.
Okay, so we've traced the whole journey. This seemingly harmless sweet liquid gets ingested. The liver enzyme, alcohol dehydrogenase, kicks things off. Glycolic acid builds up, causing dangerous acidosis. Then oxalic acid appears, stealing calcium and forming kidney-damaging crystals.
That's the chain reaction.
And the diagnosis relies heavily on catching that shift, right? From the early osmolar gap, when the parent poison is still there, to the later dangerous anion gap, when the toxic acids have taken over. Timing is absolutely critical.
Absolutely. Managing these cases effectively requires a coordinated approach. Often it means getting advice from a medical toxicologist or your regional poison control center. They have the specific expertise.
And the prognosis, if caught and treated promptly.
The good news is the prognosis can be quite good. With rapid diagnosis and appropriate treatment using antidotes and dialysis if needed, patients often make a full recovery. Even if they develop acute kidney injury, recovery of kidney function is actually the norm over time.
That's encouraging. But it underscores the importance of prevention, doesn't it?
Immensely. Keeping antifreeze and any products containing ethylene glycol in their original, clearly labeled containers, storing them securely, locked away if possible, far out of the reach and sight of children, that sweet taste makes vigilance absolutely essential.
Definitely. Paradox.
Right. We have this excellent antidote, fombisol. Safe, effective, but using it optimally relies on rapid diagnosis. Yet the definitive lab test, the gas chromatography for the EG level, often takes too long to be clinically useful in the immediate decision-making phase.
So clinicians are forced to rely on interpreting those subtle, dynamic changes in the patient's blood chemistry, watching the osmolar gap potentially close as the anion gap widens, making a life-or-death treatment decision based on the movement of these two invisible numbers.
Exactly. How critical is that skill, that reliance on interpreting the body's internal chemical conversation in real time when the clock is ticking so fast? It really highlights the challenge and the drama of managing this particular poisoning. Something for you to mull over.